you're not supposed to have a ruptured device. Don't let anybody tell you that's okay. If you stretch that thing apart, you can look right through it. It's not waterproof. The gel that's ruptured is going to interact with your tissues. That interaction is not normal, and it leads to
Mm.
more inflammation. If there's an infection in there, that produces something called oxylipin tenhome. And recently, a paper has shown that this molecule is increased in patients who are suffering with more fatigue symptoms from breast implant illness. The implants sometimes will create a response in the tissues that produces calcium like an eggshell. If you follow me on Instagram, you'll hear me kind of cracking one of these things open.
Right.
That firmness is like calcium. It's almost just a response to that placement of a device. I still have people show up who've had implants for like 30 or 40 years. Unless you're into classic cars, nobody drives a car from the 60s. If I was running your team, I would not put you in a car that wasn't safe. I made my team listen to your show with Brian.
Oh,
And
and
because I have something called a no-cut facelift, so I don't use a scalpel to do a facelift. It's all based on technology. I was going to say, like, that guy obviously has one, a shit ton of money. And two, when you have that, access to anything is, possible if you know, in fact, what to access.
right.
So the thing that we have is a hollowed out microneedling system that takes skin out without leaving a scar.
It's the coring one, right? It's where it's basically you score like a tiny little cylinder of skin.
Right.
You pull it out. It's not enough to leave a scar, but it reduces the amount of skin that you actually have, right?
And for someone like you or him who knows in terms of understanding detox really well, it'll work infinitely better than somebody who doesn't really understand that concept because I've done it for people like JJ Virgin and Dave Asprey, and it
You
works.
did, Dave?
Yeah, that's
Oh, that's the first time I heard about it.
6 inches off his back.
Yeah, he's had it done a couple times. And he did his face too. I mean, like he'll try anything. While he will try anything, he's also extremely educated in his decisions as to what he's going to try. So, like, he's one of those guys that's like, you got to do this. I'd be like, okay.
Well, that's why when I heard one, you did a really good job with him because he's a super bright guy, but he's very different in talking
You're
to.
talking about Brian Johnson, of course, for those who are not 100% sure who you're talking about.
Yeah.
Yeah, I mean, Brian Johnson, the guy, the slogan, don't die. He's obviously big on longevity, but he also does a lot of other aesthetic treatments to everything from skin to hair to you name it. So he's like, he's the test dummy of his own. Test smarty, I should say. How did you get into the space of Explant and BII? And, obviously that's, the foundation of us getting introduced. Where did that come from? What was your evolution? I imagine you did implants before you did explants.
Yeah, when I was in med school, I think about a month, and my sister called me and told me she had breast cancer. And of course, I'm now the doctor, even though I'd been in school for like 4 weeks, and just to sort it out. And fortunately, that day the lecture was being given by an oncologist. And afterwards, I asked him, I'm like, hey, my sister called me and said she has breast cancer, and she was in a different city, and he had a colleague there. He said, hey, that's not a problem. I'll call my colleague and I'll set up an appointment with her. And I flew down and went to that appointment with her. And ultimately, she went through mastectomies, reconstruction, chemotherapy, suffered some cardiac problems from chemotherapy, and lived overall a relatively long period of time. And she recently passed away of a recurrence just in the new year. And I it's one of those things where you talk about trauma a lot, and I had always kind of put that in the back. And people ask me why I went into surgery and why I did so much oncology reconstruction, because that was my career basically. And it was mostly about cancer reconstruction for women with breast cancer.
Mm.
And, I never likened it to that as the sentinel event of why I did all that work and why I was so passionate about that work. But of course, when you think about it, that's a driving force of why I did all that for so many years. So the short answer is I did oncologic reconstruction for head and neck cancer, sarcomas, which are tumors of muscle and fat and soft tissues. And then I did, of course, breast cancer reconstruction, which is unfortunately the most prevalent cancer we take care of in plastic surgery. And to implants, I was never somebody who put in a lot of implants. I did a specific type of surgery called microsurgery, and it allowed me to do reconstruction that was with your own tissue. So
Hmm.
I was seeing problems with implants from radiation and people getting infections from chemotherapy. And then I would do other procedures, taking the tissue of the abdomen or other areas of the body to reconstruct after removing those implants that had um, become problematic for the patients, either through those therapies or from scarring, which happens. And there were lots of issues because everybody should understand that an implant, one, is never a lifetime device, to be clear. And anytime, you're trying to explain that risk benefit ratio to a woman who's going to go through breast cancer treatment, it's pretty complicated. So I never spoke with a lot of young people in my career, fortunately. So I was not somebody trying to um, do augmentations for cosmetic for young patients. That was not my uh, ability anyway. My unique ability was to take care of cancer patients. So that's what I, predominantly did. And then I became very good at taking care of problems with implants and those patients who I could help without the bigger surgeries, I would help. So I got a lot of experience, we'll say, taking care of implant problems.
Hmm.
And in 2016, I had a breast cancer patient come and want to go flat. So everybody listening, you can always choose to have an aesthetic flat procedure. And this patient had, after many, many years, decided not to have a reconstruction anymore. There was nothing wrong on physical exam or in her laboratory analysis, any of the studies. And I did her removal. I took out all the scar tissue. I always did everything the same way for cancer patients because that's how I was taught in training. I would take out all of the scar tissue and send that to pathology because you want to make sure that somebody who had had breast cancer didn't have a recurrence.
Hmm.
And then I would always check all of that. We would think of like a Q-tip swab, and you would
Hmm.
send that for a culture, the old-fashioned culture that you would put on a
Hmm.
agar plate, a little gel plate, and they would incubate. And so at a week, you get all the studies back, and first and foremost, you don't want to have any patient have a recurrence, so you make sure that there's no recurrence. And then the report comes back about any bacteria or fungi
Right.
or like that, and she had an E. coli infection. And so I was like, how in the hell did
And
I
she
miss?
didn't know.
No.
Yeah. I thought
And
that would make you sick.
so her only symptom when we went back through everything, and this is, how I missed this, was her symptom was being fatigued, which a lot of patients who've had chemotherapy or other cancer treatment have fatigue from bone marrow suppression. It's pretty common. And so I let that commonality kind of dupe me. And she put me on a Facebook group for plastic surgeons who do explant procedures. And then all of a sudden, my office started having people call for me to take out their implants. And my office was like, why are they asking us to take out their implants, Dr. Whitfield? And I was like, I don't know. I mean, that kind of moment was critical in, highlighting what we don't know, right? I didn't know she had an E. coli infection. I had no way of knowing that. Now I just had people start showing up with different symptoms.
Hmm.
Some of them didn't make sense to me. Like, oh, this whole
Hmm.
thing with brain fog in 2016 was super confusing to me.
Yeah.
And I was like, what does that mean? So if I would ask you, I said, Danica, what does brain fog mean to you? And they would tell me, well, I can't remember where I put my keys, or sometimes I forget my kids' names. And I was like, okay, well, that's short-term memory loss. I get
Yeah,
that.
that sounds a lot worse than brain fog.
But I didn't understand it. Like I didn't have the slang to communicate with the patients about that. And now, obviously, I just came out of consultation, and now it's all like, several thousand patients later, several stories along the same line, several thousand stories. It all becomes very kind of clear. And now there's research. Like I just published a paper about a small amount of our experience, 700 patients, explants, and how many patients have bacterial contamination. It's almost a third. So
I mean, there's so much that we can go into about my own experience about all this because for anyone who isn't aware, I had implants for 7.5 years. I got fairly sick. I had like endocrine disruption, like suppression, really, gut issues, dysbiosis. hair loss or loss of lack of hair growth, weight gain, just general systemic inflammation of the body. And so that's why this interview is important to me, and why I think that, and it resonated with so many people, me sharing my story, which is why I know that there's a continuation of this, the demand and the curiosity for this information, because, this isn't a mystery anymore. Like, we don't get told the full truth in general with many, many things, especially when it comes to medicine and wellness. I can remember the days when silicone was banned because it wasn't healthy. And then I remember when I was getting them, I was like, oh, they must be safe. I'll get them. And thank God they're back, because, I don't want water bags in me. I want that soft, gushy stuff. So, it just didn't even cross my mind that they would be available if they were so detrimental to your health. And so what are some of those common themes that you found with your patients across the board of the, hundreds and hundreds of explants and lab testing that you've done, and anecdotal stories from your patients?
Well, from 2016 to like the end of 18, we were learning about how many people were being affected and symptomatic, and I would do the surgery. And it was kind of like my early oncology experience. I was, establishing, what I would later become my sharp method in terms of looking at different tests, genetic testing, toxicity testing. Now we do stool testing, food sensitivity testing, metabolomics, and hormone testing. At the end of 18, I had a nurse come to me from another state, and her sister lived in Austin. So she wanted to have her explant with me and stay with her sister. I did her explant, and she clearly had an infected implant when I took it out. So I went out to her spouse and I said, hey, I'm going to get the studies back here in about a week. I'll know exactly what to do, and we'll get her treated, and it'll be fine. Well, when that study came back, there was no cancer, which obviously we don't want to ever see that. There's so many breast implant associated cancers now, lymphomas and squamous cell carcinomas and all these things. So I'm always, given my background, I'm always worried about that. It's number one. And then the results about bacteria or fungi came back, and there was nothing. And I was like, well, that's a bunch of bullshit. I know there's something there. The technique is insensitive to what's there. So the bacteria that forms on the surface of an implant can happen three ways. It can happen from somebody handing me a contaminated implant and I placing it. It can get contaminated by placement of the implant into the body. So that's driven by, technique, the surgeon, how they're doing it. And the third, which is the most common, is through your bloodstream. So somebody gets an infection, like a cut in the skin, a urinary tract infection, a GI infection, a cold, whatever. The most common example is back when we used to use mechanical heart valves for heart valve replacement. If somebody went and had a teeth cleaning, they would give you a prescription to start an oral antibiotic prior to that.
Yeah, that's right.
You get endocarditis.
Yeah.
So none of this is like new.
Right.
All of the patients who I did cancer reconstruction on that had an implant always had a standing prescription for an oral antibiotic prior to teeth cleaning, because that was just the standard that we carried in our group. I would guarantee you that's not, and you probably weren't told that when you got implants. So that's a disconnect, right?
You're saying that you should be prescribed antibiotics no matter what?
Yeah. If you're going to get a teeth cleaning,
yeah,
Provatellas, there's a lot of bacteria in your mouth, and they stir the stuff up and it gets in your bloodstream. So if you want to be as conservative as possible, and I worked with immunosuppressed patients with cancer, so you don't take chances with those patients. So I would always treat my cancer patients the same as I treated a cosmetic patient. I didn't treat them independently.
Right.
So the follow-up was the same. Everything was the same. So this patient I knew had a problem. So I basically created a relationship with a company called MicroGen who's done all of my tests since that point with PCR testing. So PCR testing, everybody remembers from the pandemic, it's more sensitive than the antigen. So it's basically a DNA test that looks for, in this setting, 150 types of bacteria, fungi, and mycobacteria. If something exists outside of that panel, then it'll get missed. But otherwise, you're going to get the most accurate information about that. And in our series, compared to other series, it's roughly the same. The majority in mine is called Cutibacterium acnes, which is in high concentrations on our skin, the chest, face, shoulders, neck. And then in another series, it's staph epidermidis, which is also found in our skin. And that's the second most common in my study. So I just started doing this and checking this because I didn't want to, if I had done your case, like Dr. Parsons, who I know did your case.
Oh, you do? Oh, man.
If I do your case, you're going to have these things in your chart. You're going to have all of the testing that looks at your pathology, because I've had 1 in 1,000 have a lymphoma. I just have had several cases of early stage breast cancer as well. So I don't fiddle with any of that stuff, given my sister and my background in oncology. And then I always am going to have this PCR testing so that you know exactly what was there.
Yeah.
We have a video, still pictures, so everybody knows. And I do the video because I do, sometimes 8 or 10 a week, and I can't remember and keep everything straight. So I will do a video in real time when I'm there in the operating room for you, so you know exactly what I found if I was concerned about something. Because when I go out and talk to the families or the spouses, I mean, they're just worried about you.
It's the medical jargon that's not exactly the roll off the tongue stuff.
Right. Right.
So it's kind of hard to remember the stuff you can't pronounce.
For sure. I try to keep it super simple.
So you're saying that a lot of times some of this stuff, because I forgot to mention that a couple of things that also were really prevalent for me, one of them was metals, for sure, was extremely high. My mercury, I had like 5 that were really high, but mercury was 170 and it's supposed to be under 5. So it was fairly elevated. In the end, I ended up testing for mold too, and that was positive as well. So you're saying a lot of this stuff, some stuff can come through contamination, but also some of it comes through just something that happens in the process of surgery that is then essentially you don't get rid of it because you're not taking the proper precautions and things like that. Like, how do all these other things develop outside of, we've got the mold, but metals and endocrine disruption and, brain fog and like extreme lethargy. Like some people can't even get out of bed, skin manifestations, random phantom joint issues. I had that. Like one of my shoulders, I could not take my right arm and put it behind my back. And I used to blame the fact that I drove mostly left-hand turns. And I was like, well, maybe I just have a shoulder impingement. But sure enough, it took a couple of years after I was done until I got them out. And then after that, that disappeared. So there's so many bizarre physiological expressions that come from essentially what we're umbrellaing as BII, which is, a pretty wide scope.
I'll define it the way I view it.
Okay.
And I view breast implant illness as chronic inflammation.
Right.
And the device, the breast implant, is just playing a component. It's just one component of a very complex problem. So genetically, most of my patients have some limitations in their ability to detoxify,
Okay.
and that hampers their immunity. So many of them have problems with vitamin D synthesis, methylation pathways,
Right.
glutathione in the liver, antioxidant pathways. And then, if your liver is not functioning as efficiently as it should, then your GI tract doesn't really function as efficiently. You can have more, we'll just say, you can have more fermentation than you should have in your GI tract if you're not eliminating waste, which is something that you have to do daily. All of that builds up, and then everything that you're describing that affects that patients have told me about symptoms, like all of the joint pain and muscle pain. It takes very little inflammation and fluid production to create a problem in a joint.
Yeah, I suppose when you think about even getting like PRP or stem cells or something like that, you think about a volume of fluid that is extremely detrimental to that joint. Like it's super sore, and that's not much. And, I mean, I've gotten sore from working out to the point where you like literally can feel a tightness in your clothes because you like retain so much fluid from inflammation. So that's a good point.
So those things are really hallmarks of what's going on with the patients. Because some patients will have implants and have absolutely no symptoms because they can detoxify what they're getting exposed to.
I think this is an important point to have a second on and just give your opinion, because I think for the people that are listening and curious about this, they either have them or know someone that has them or are thinking about it. And so the question is does it affect everyone on some level? Like, are some people minimally affected? Are some people not affected at all? Like, what is the actual chance that you are not having any symptoms as a result of some form of implant in your body?
Yeah, I answer it. Your body can handle so much in terms of exposures.
Okay.
So you drove cars, you're around all those things that were at the speedways and in the cars.
Sure.
Different set of exposures than I would have. Then you mentioned mold. Like, I live in Texas. Big problem with mold in Texas, California, Florida, Hawaii. Hawaii is the worst.
Mm-hmm.
They routinely have cutaneous problems with mold, meaning on their skin. Heavy metals, and I was going to ask you, like, so I've gotten in a ton of trouble for talking about saunas and what it does. So if your shell of your implant, which is made of silicone, whether or not you have a saline implant or silicone implant, the shell has silicone in it, and it has all of the metals associated in the curing process of the shell. I had a client, very famous client, and she was, basically getting in a barrel sauna that went up to 200, 212 Fahrenheit routinely. Her toxicity report would show like a page of heavy metals, not like 4 or 5, like you said, but a whole page. And I printed it off because I'd never seen a report like that. And I was like, well, what are you doing? How are you getting this? And her husband was like, oh, yeah, she got in the sauna, like cook herself for like an hour. And I was like, oh, okay. Well, I would assume that the process of leaching chemicals out of a device is well known. So when you superheat something, and people will argue, well, you're not reaching the point of melting the implant's shell, but if your shell is breaking down because things rupture over time, if it's already degrading and you're heating it, how would you know that something wasn't coming out of the shell into the body? I think I'm
Sure.
one of the few people like on earth who has a test result that shows that. And then all I did was take her implant and everything out intact, and all of that disappeared on her next test. She
Yeah,
didn't.
I mean, my job, especially in NASCAR, was to sit in a sauna
Right.
for 4 or 5 hours every weekend. Well, that was just the race. That doesn't even include practice or qualifying or anything like that. I mean, IndyCar was hot, but it was more physical than it was heat. NASCAR was heat, and I had implants basically my whole NASCAR career. So, yeah.
When I heard that, I wanted to know like what your thoughts were about.
Yeah. I don't do very well with heat. I still don't do heat very much because I get perioral dermatitis flare up if I do too much, which really is telling me like I don't know if this is true, but I've heard that basically the inside out of your stomach is essentially your face. Is that an accurate sort of like indication for someone that has anything wrong with their skin, that they could look to their gut health to be the first stop?
Kelly Blodgett is a biologic dentist, and I had him on my show, and we talked about this. And it's very true. Like, someone who has problems orally is a real tell to everything else going on.
Mm-hmm.
Um, when we have patients, and I had a patient recently tell me they went to the dentist and they were removing black material from under their gum line.
Yikes.
Black
You sure
material,
that's mold?
yeah, I only equate that
Not
with.
a pepper flake.
So I was like, that is not good. Those are, to your point, oral health, and he would say it, especially like when you have somebody who's having oral health issues, and the new coach who took over Football Club Barcelona made all of his patients get an oral exam by a dentist for this reason, because your gut health is the beginning of the gut is your mouth. If you're, constantly bringing bacteria downstream to that, you're going to burden the gut.
But even another step further on the outside would be the skin itself, because like you hear some people talk about too that they have horrible breakouts and they cut out dairy and it makes a massive difference with their so for me that perioral dermatitis seems to get worse when I do heat. And I went through such heavy detoxing for a year and a half, and heat was part of it, and like to the point of misery heat. And man, all I just never seemed to make me feel better. I was also very exhausted from it.
Yeah, I can probably I don't ever have my patients start any form of sauna, IR or otherwise, for about 90 days because you can increase, like you're describing, probably a level of Herxenheimer type reaction where you're detoxing too quickly.
Mm,
And even patients who take binders, we have a whole detox
sure.
protocol. It's probably more than your system can
Yeah.
handle.
You mean I shouldn't have been taking suppositories, also like blood-brain barrier, mercury tinctures to just detoxify that, coffee enemas, heat, sauna, you mean I was stacking too many hacks on top of each other? Yeah, that's my story.
And you said you didn't like hyperbaric because it was boring. I can
So boring.
I
Hyperbaric's the most boring thing in the whole wide world.
I did that this morning. I have one in my office. So all of my
Oh,
patients have access to hyperbaric because it promotes better, well, any oxygenation improvement in tissues that have been operated on will, improve efficiencies as we heal. And then I have a lymphatic therapist and a bunch of devices from New Zealand to really promote lymphatic drainage. I don't use drains at all, so I haven't used
yeah.
them.
Oh, yeah. Yeah, I didn't feel like I needed drains any either. When I got them in, I didn't have drains. When I got them out, I got drains, and I had the drains in for honestly, it was less than 48 hours. There was almost nothing. But
Yeah. Like Shawn, you had some small implants too, because I remember.
yeah, they were very small, and they were, yeah. I mean, I was like literally like putting my hands behind my back, going like this, doing down dog within like 2 days, and he was freaking out. And but you mentioned lymphatic drainage. So I found lymphatic drainage to be one of the most helpful tools for me. I mean, I still keep up with it with gua shaing and working like the six main lymph node zones behind my ears, my collarbones, under my armpits, stomach, groin, behind the knees. Like, and I do that in front of the red light when I'm home. When I'm not, I don't, I just don't add that stack on. But what is it that happens with the lymphatic system with when you have implants, or you have these issues going on? Why was that so helpful to me? Why does that get so disrupted? Does it actually get clogged?
That's your filtration system, basically.
Mm,
So if you're trying to detoxify, just like, cancer is going to go to a lymph node basin. That's why they always check the lymph node in the armpit. They call it the sentinel lymph node. If you're having, like, many patients who have a ruptured device will actually get silicone in a lymph node.
okay.
And, and that's how they learn that they had a problem. They
Mm,
had swelling in the armpit that alerted them, like they may have, you know, everybody who feels any lymph nodes is worried about cancer, number one.
mm, mm,
So they go get a, evaluation and they'll say, well, this looks like it has characteristics consistent with silicone. They'll get, the next study. I have a lot of people come with Pronovo screening now with MRIs, Pronovo's screening MRI service, and they'll show ruptures. And just so everybody listening, you're not supposed to have a ruptured device. Don't let anybody tell you that's okay because it's not. And I'll
mm.
explain it this way. Everybody may be familiar with something like a knitted or crocheted, uh, blanket. If you stretch that thing apart, you can look right through it. So your scar capsule is like that. It's not waterproof. It's not fireproof. The implant, if it's ruptured, the gel that's ruptured is going to interact with your tissues. And don't let anybody try to lead you down the road that it can't. That interaction is not normal and it leads to
Mm,
more inflammation. Now, if there's an infection in there or a low-grade contaminant like I've described, that can interact with your tissues, and specifically a fatty acid called oleic acid in your tissue, your breast tissue. That produces something called a molecule called oxylipin tenhome. And recently, a paper has shown that this molecule is increased in patients who are suffering with more fatigue symptoms from breast implant illness or associated with breast implant illness. They've also been able to reproduce it in an animal model and produce fatigue in the animals. So I think, like, we need to move beyond, like, this is not a problem, or this is not got scientific data to it. I've published a huge series, the largest in the world with PCR testing showing the incidence. And then this scientist who's out of Indiana University Medical Center, he showed that this molecule is ramped up in patients who are more symptomatic with fatigue. And he's shown it in an animal model. And he's shown there's other molecules like it. So
Hmm.
is this really that complicated anymore? Are we making this like, is this still a thing that I have to defend all the time? It shouldn't be.
You had mentioned the capsule, and just as another sort of point of reference for people listening, one thing that happened to me was that they were fine for a couple of years, and then one got hard, and then I thought, oh, maybe I hit a wall, so I had to check to see if it was ruptured. It was fine. Time had just passed, and I thought, oh, I get them out, or I'll replace them, or I'll replace one. I don't know. And then the other one got hard, and that was after I was done racing completely. So I was like, oh, that's weird. So, what does that mean when an implant gets forms continuously more scar tissue?
Yeah, it can vary depending on what the quality of the scar is like. And so I think of it, just like pages of a magazine. A super thin one is like 1 page or 2 pages thick, but as you're describing it, it's getting thicker and thicker and
Yeah,
thicker. So I think of it as one, your body's responding to what's going on and it's trying to wall it off,
right.
get it out of your body. That's a way to view it. The other is the implants sometimes will create a response in the tissues that produces calcium like an eggshell. And that's where I sometimes, if you follow me on Instagram, you'll hear me kind of cracking one of these things open.
Right, right.
That firmness is really like calcium.
Uh-huh.
And that is a response that we see, and we don't know exactly why each person is doing that. Sometimes
Hmm.
when people get, surgery to repair a bone, they'll form what's called heterotopic ossification, or they'll form extra bone. It's almost just a response to that placement of a device. I see it a lot more in older implants. So I still have people show up who've had implants for like 30 or 40 years. Unless you're into classic cars, nobody drives a car from the 60s.
No, they must be rock hard, no matter what. Have you ever seen a soft implant after 30 years?
Rarely they will be soft and normal as you're describing because you
Mhm.
can't tell the shell characteristics. I always like put them on video and I squish them around to see if they've had a integrity issue, but I don't have a microscope at the,
Yeah.
to look at it, so I don't know. But many times they're breaking down, obviously, because the rupture rate increases, 0.5% per year after 8 to 10 years. So I'm always, when people show up and they're like, well, the MRI says I don't have a rupture. I'm just like, well, okay. First of all, an MRI with you lying on your back is not a good exam for a breast implant because gravity is not weighing on the implant or pulling it away from the chest wall. Most of them will have, if they leak, a posterior leak up against the chest wall. This has just been my experience doing
Hmm.
thousands of these. And you will not find that until you're the surgeon taking that out.
Exactly. I'm trying to remember if I was face up or face down when I had mine checked, but mine didn't have the calcium, but they were so much scar tissue that both of the implants were folded inside of the
Right.
capsule.
Right. Yeah. And
Yeah.
that creates a lot of pressure and can create, for the patient, they can get a lot of sensory symptoms, nerve pain,
Hmm.
pulling, tightness, pressure, all sorts of.
Oh yeah, I could like feel it. I could like feel where the fold was, where it was kind of poking out to the side. Like I could literally feel like the silicone. So if somebody is thinking about getting it out, I know that there's like a whole decision-making process and there's also a financial decision-making process and the way that you get them removed in the process. For anyone curious, I had a full en bloc procedure where you end up taking the entire implant capsule all out together. I'm not sure how it fit out the hole it did, but it did. I don't want to know. I don't want to see a video. I don't care. I'm out. Just give me the drugs. But there are procedures in which to remove them that are more safe, less safe for toxin exposure. So please explain to people what their options are and what your recommendation is.
Yeah. On block is the term, it's a pathology term. So
Okay.
it's taking it out without being inside. So think of like we talked about with cancer. We don't want to be inside the cancer. Obviously, we don't want to spread that around. So we're always trying to take things out intact. So I always use the analogy as I'm trying to take it out like an undisturbed Easter egg. Like I don't want to crack the shell of the Easter egg. And if there is a contaminant, if there is a breast implant associated cancer, then all those things that are inside, that's where they should be, are left inside. And when I take everything out, from a safety perspective, there's not a safety issue with taking things off of the rib surfaces. I mean, if you're concerned about that, then you should seek out someone with my level of experience, and it will not be an issue. So that's just an experience issue. It's not a safety issue.
So if the doctor is not willing to do an en bloc procedure, it's probably because they don't have the confidence to do it correctly.
Yeah, I mean, Shawn, your doctor, trained at the Mayo Clinic and did chest wall reconstruction as part of his training. I did an entire 20-year career of just oncology care. So from breast cancer to chest wall cancer, I mean, you name something, there's not anything that was going to be like, oh, I can't do that.
Another thing that a lot of people face is their doctor not wanting to do the procedure or not believing in them. And I mean, I've heard this so many times, and I'm like, you just tell them what you want. Like, you're the patient asking for something, but there are some red flags that I think people should know about. Like, if they don't want to do it, if they're down on the whole BII perspective, if they don't want to do a certain kind of procedure, these might be indications that someone needs to look in another direction for doctors.
I'm glad you said it that way. So I'll tell you 100%. Like, if I was running your team, I would not put you in a car that wasn't safe.
Right.
If you look at me in my eyes and I say, I don't want to do it, you should not try to convince me I should do it for you.
Right.
You don't want to ever ask some surgeon to do something they're not comfortable with. Yep. You should just say, thank you, and get out of the door.
Yep.
Because that's not the right way for this problem. Like, you want someone with a level of expertise where I can just calmly explain to you, just like Dr. Parsons did for you, what's going to happen and what's the expected outcome and the expected risk benefit ratio, and get it taken care of. Because that's what it should be. It's a procedure that I've done thousands of times, and he's done thousands of times. So it's, for us, that's all a big deal.
Do you think that over time of doing so many explants and hearing so many stories, that whether it's you or even just your opinion, do you think that this will continue to sway doctors to reducing the amount of implants they're wanting or willing to do? Is it that level of a scary sort of situation, like, or not?
I think a lot of hosts try to put me in a position to ask me if what would I do if my daughter asked me about implants. And so my daughter's a Leo. For everybody who knows how Leos are, they don't listen very well. They're going to form their own opinions. And even though I've written a book about it, even though I have shows about it, even though I've done thousands of these, if she had her heart set on it, then that's what she would do. So I think, from my perspective, everybody in my position as a plastic surgeon needs to understand how to explain to you the risks and benefits of fat transfers, implants, both, so that you can make an informed decision. Because at the end of the day, you have to make an informed decision or a shared decision with the surgeon who's going to help you. So for everybody listening, your audience, and I really appreciate your audience, like, I did this for cancer all the time. These are very long discussions. I was usually the last person in the line of discussion. And I started my career, even though I trained forever, I think I was 34 when I started. I'm old now. But
wow, I like retired at about that age.
Right. I'm 55 now. So the point being, those discussions, they're complicated enough. But when you're a young person, and many of the people who've made this decision make it when they're very young. For me, it was very easy. If you came into me and asked me to perform a breast augmentation, I would go through the same discussion. If you said you wanted a really small implant, I'd be like, okay, well, a fat transfer can suffice for a whole cup size. If that meets your expectation, that's a very natural, holistic way to do it. It's very safe. It's very effective. If you want more than that, then you're kind of leaning into the implant realm, and there's a risk benefit ratio associated with that. Well, now fast forward, from, 2004 when I started practice to now, 2024, those would be a very different, risk benefit ratio discussion. I'd have to now explain, in my experience now, about a third of these are going to develop a problem with the low-grade bacterial contaminant. And we know in these studies that this contaminant can interact with your tissue and create this substance that can make you fatigued. It may also contribute to, like you experienced, joint pain or muscle pain. Other people have palpitations and they have all sorts of gut dysfunction. I don't know what all of this is going to lead to, but chronic inflammation can exist without implants. But if you don't understand chronic inflammation and its ability to exist with implants, you're going to miss this problem every single day.
I don't even know. Was there sort of a smoking gun or a breaking story or someone's experience that sort of woke everyone up to this possibility of implants making you sick?
Actually, your story was going to do that,
Oh,
but it really didn't.
didn't take people completely away from it.
No, I think there's a lack of everybody's attention span is about a millisecond.
What? Yeah, totally.
That's the
And there's
problem.
also just cognitive dissonance. You just don't want to believe what you don't want to believe. I mean, we experience that in many different realms of reality these days. So, I mean, yeah, sometimes there's nothing you can say. Like as a parent, you realize this, I'm sure very well. Like you can say something to your kids and they still have their own idea of what they're going to do and they sometimes have to touch the hot water.
Of course, we all did.
Let me ask real quick because I do want to ask because I think about like, yes, I understand there's vanity implants, there's just aesthetic implants for breast cancer patients and people like that. But then there's also different kinds of implants like metal and plates and things like that. Do these carry the same kinds of risks? Because of course, any little piece that gets in the body will form some scar tissue around it. So is it having the same action reaction? Or are there some things implanted in the body that are much less concerning? Because some of them are quite necessary, right? A knee replacement is like a, standard of life, standard of just, comfort of living.
Yeah, I think, I've had to work with orthopedic surgeons. I've worked with neurosurgeons, cardiac surgeons. Everybody who puts in an implant will face a problem with an infection with the implant they've placed. If they operate long enough, that's going to happen. You mentioned a very complicated situation. If someone gets an infected knee implant, what happens? It's a really difficult scenario for the patient, the providers. And yes, whether it's a shoulder, hip, knee, breast, they can all get a biofilm contamination. There's plenty of examples in the literature of this. And I think, if you look at the orthopedic literature, the reports will say that that substance, the metal, if you will, the titanium, is less reactive
Okay.
than the breast implant. And so do they experience these types of symptoms? Well, I've taken care of plenty of infected orthopedic situations, and it is complicated. Is it the same? I can't equate them to being the same because usually those folks, in my experience, don't have this kind of chronic low-grade infection. They have a hot, flaming kind of mess going on. So
Yeah.
can they have that type of situation? Sure. It's just not as prevalent, as I see in the breast.
You mentioned biofilm, and I think that's something important because I know that's something you've researched and understand really, really well. So, what is that? And my only experience with biofilm would be, and this is like maybe a TMI story, but I was doing suppositories, and like I was given this one that helps remove like a biofilm. Essentially, it was like a horrible experience, and I stopped doing suppositories altogether, and it was like almost the end of my deep dive on detox because I felt so terrible from it. But what is biofilm and please explain what we need to know about it.
Yeah, so biofilm, if we look at it, the first example really is the plaque on your teeth. So that was examined under a microscope, and that's really how you identify biofilm. So if you just think of bacteria, if you get a bunch of bacteria enough to form a little village of bacteria, that's basically biofilm. It's an aggregation of
Oh,
bacteria.
okay.
That's what plaque is on your teeth. Some of them readily, when you get that group of bacteria and the biofilm will produce, it's almost like a goo layer, if you want to think of it. It makes it so your body can't get rid of it. And so it's uniquely positioned to make an implant, hip, knee, breast, dental, really a chronic low grade inflammatory situation that your body's constantly reacting to.
You take a some kind of supplement to break it down?
So you can't really make it go away in that manner. An antibiotic won't clear it. A kinase, a lot of people use different types of kinases to break down scar. It doesn't really bust up and eliminate the biofilm we're describing because the surface is the problem. It's stuck to a surface that has no blood flow. It's a hip implant, a knee implant, a breast implant in this situation, a dental implant. If you listen to the biologic dentists talk about it, they send these things off and find all sorts of bacteria and viruses adhered to the old, but where they did the root canal and it died. So there's just, I guess, countless examples of when you don't have a good blood supply or no blood supply in the case of an implant. It's an easy place for bacteria to develop these colonies and produce this, aggregate and biofilm and make it so that it's really taxing to the immune system. And you just think about it, if someone's immunosuppressed for cancer, they're more susceptible to infections. If they've had surgery, they become more susceptible to infections.
Mm, really? Like the more you have, the more sensitive you become?
Well, these triggering events seem to be what really set off my patients. And it can be, you've talked about like different traumas. I see people have problems with a death in the family, delivery of a child, renovating a home, changing addresses, moving. All these things are triggering events to my patients. And, you would think, well, those are more emotional. Well, that's all tied together. And
I'm glad you
you
said that.
you can't really escape that situation and you can't isolate that situation because everything is linked.
I'm glad you said that, and I'm curious your perspective, to for you to expand a little bit more on this because this is a little bit more of I think the holistic side of wellness, but in my own experience, like I worked out way too much. Like my diet was probably not like quite right. It didn't have enough variety, probably not enough certain kinds of carbohydrates. I was far too stressed, emotional stress, the physical stress I put on it, as well as then, of course, what I had going on that wasn't going anywhere, like the implants. I really started to understand even heat or cold, right? Like those are stressors to the body. Those aren't nothing. Is this a conversation that you have with a lot of your patients? Is there a holistic conversation that goes on with all the things going on? Because that's the key that I had to learn was that the system is one and that there isn't a bucket for emotions, a bucket for physical stress, a bucket for emotional, like they're all one and you can't keep taxing that one system.
Yeah, I'll answer this way. I get asked, do I tell people they need an explant? And I will tell you, I never tell a patient what they need.
Right.
Their
But there's a
mindset.
whole conversation about the other sort of taxing things or the viral load of their life.
So it's the mindset. So basically, they come in, and first of all, no one comes in wanting surgery. Like nobody wants to have surgery. You didn't want to have surgery. You had in your mind got to a point because of all the burden and all
Hmm.
the different
Hmm.
stressors.
Hmm.
You're like, this is the last effing thing I want to do, but I'm going to go and I'm going to see if this is going to solve this problem. Because I would say women as a whole can handle a ton more stress and burden management
Hmm.
than men can.
I
Men
see.
don't do well with pain. They
Hmm.
don't do well with the kind of
Hmm.
pushing through that I would see.
Really? Is there a biological reason? I'm not going to sit here as a woman and be like, oh, yeah, go us. I'm curious. I feel
Uh,
like I've heard something about men having like the reason why they feel much worse when they're sick is because hormonally there are triggers that actually do make them feel significantly worse than a female would.
I don't, I think it's more of a mindset issue. Like
Really? Huh.
that, that kind of, I think women can, and And granted, men can push themselves and deliver, but I just see this kind of ability of my patients to drive themselves and get up in the face of what I would consider to be physically daunting situations with
Mhm.
fatigue and inflammation and pain and sit there in front of me explaining this, but can't sit still. They have so much pain, they have to shift around
Yeah.
all the time. And it's like, it's going to, if they sat in one position too long, that joint that's hurting them would get exquisitely painful, or they're having neurologic symptoms or something. It's just the angst with which you see everybody react. And then, we speak to them for a period of time. And I try to get everybody to understand it's a really safe place when you come speak to us. There's not anything you're going to tell me that I haven't heard in, almost 30 years of taking care of patients. I believe the problem. I understand the problem very well. And, whether it's our program, whether it's counseling for nutrition or mindset, and we do speak about mindset, because if you're not in the right mindset, the level of kind of spin you can get into after surgery is just endless. Once you
Mm,
get in your own headspace,
sure.
it's a dark situation. And you know, everybody says I'm ready. Really? Really? Have you done some EDMR? Have you done anything to make sure you're ready? Because I'm not the problem about being ready. Everybody asks me every morning, Danica, before surgery, did I sleep well?
Of course.
All
Of
right.
course.
And
Nobody's excited about it. The last thing I say to my doctor is, please take good care of me.
right. I mean,
Like as
yeah,
if that's going to make them try harder.
right. And like, just so you know, after doing like 20,000 cases, if I can't operate on you or I slept or not, you shouldn't have chosen me.
Right. The only thing that's going to happen is I croak while it happens. That's the only thing that's going to stop this from going well.
Yeah, I'm good. Don't worry about me.
Yeah.
I mean,
Yeah. So what is you talked about fast transfer and I've heard about that too. And I'm kind of curious about some of the other procedures and like, the future of implants, the future of other procedures like fat transfer. I'm even curious what your perspective is on things uh like silica, like injections in the face, like the hyaluronic acid and filler and all that stuff. I mean, these are all the things that we put in our body. And I mean, in full disclosure, I tried filler one time in my lips, very small amount, and I hated it. Like it like made I woke up in the morning and I felt like they were swollen. And I'm like, pretty sure my body's telling me that this is not supposed to be there. So, I just think about how young people are starting with this. So, what maybe we start with fat transfer just on the heels of sort of talking about so much of the breast implants and explants. I think one of the fears with the fat transfer is that no one's scared to get rid of fat somewhere else, that's for sure, but the results not being long lasting.
well, I think if you look at 20 years ago in South America, they started doing butt augmentation with fat, the Brazilian butt lift. And then in this country, we'll just say about 10-ish years ago, and about what is it? We'll say 15, 16, 17, there were several deaths in Miami and LA from fat transfers to butts. And they were both unnecessary and they're more technical misadventures. Fat transfers are very simple to do. I've done several thousand fat transfers for cancer patients, cosmetic patients. They work given a certain set of parameters. And if you think of the two groups, if someone's getting a butt done, they're typically a younger patient. They may be a little bit heavier patient, and you're recontouring the waist, the abdomen, and the inner outer thighs to create a shape and a bigger butt. Fine. Does that go away at, 5 years, 10 years, 20 years? No. In fact, they typically get bigger because we usually gain weight. We don't.
Right.
So if you look at a fat transfer in a face, that's what's going to happen in a face. If you put fat in someone's face when they're younger, uniformly it heals. And then over time, those people gain weight and it gets fuller. So what's the problem with the breast? The problem, if you want to think of it, is the hormonal environment of the breast is changing over time. So if you can dial it back, and I always tell people you want to be closer to 20 than 80. Unfortunately, now I'm closer to 80 than I am 20. So when you're doing fat transfers, it's much easier when you're younger or when we try to make your body younger, like Brian Johnson's trying to do all the time to himself, right? So he's trying to walk it back. And when you walk it back, meaning you're getting your hormones in balance, your thyroid function, your sex hormones, your gut health, your, qualities, if you will, of air and fluid that you put in your body. Because if you just think of your body like you used to think of your race car, it's a performance device.
100%.
And if you don't really monitor what you put in,
Yep.
you should have no expectation of what you get out of it.
Yeah. And just like with a race car, when something's weak, when something weakens, the another thing breaks. Like it's a chain reaction. It's not always directly the one thing. It's all quite systemic.
So fat transfers work. It's the oldest filler. It's a natural filler. Of course it works. It's their own genetic material. Of course it works. So given these parameters, that's how I explain it to my patients. And I'm not someone saying, it's a flip of a coin. Well, who the hell wants to do that? That's just ridiculous. So it's easy, for someone who doesn't have the experience doing fat transfers to say an implant is always going to be better. Well, the risk profile of the implant is tenfold worse than a fat transfer.
So it's essentially like a bacterial sort of, like just same thing with anytime you open someone up, or, you can get an infection. But outside of that, transferring your own fat from one place to another, the quality of the fat's the same. Essentially, you're just moving things around. Opening you up is the danger.
Yeah. And these are super small spots. I mean, yeah. So that's a basic, thing that face, breast, butt. Okay, we move fat from one place to another. People ask me all the time about putting fat in their face. And because I already told you, and you can go look at the studies, you're going to gain weight over time, and that's going to get bigger, not smaller. And
You're
so
gonna need some fat replacement for those buccal fat, removed people that don't look quite the way they wanted to.
right. So that's why we didn't do that. I've never done that
Oh,
procedure
really? Oh, wow.
because you know where that's going to end up.
Yeah,
There's no
right.
reason, and there's a device called Evoke that you wear like a pair of headphones down here that will reduce that fat.
Wow.
And then we have soft wave in the office to tighten skin.
Yeah,
So
I like
the,
soft wave. I've done that a few times.
so the underlying theme is always tighten before you fill. That way you don't have to fill as much.
Exactly. Exactly. The face being an interesting thing because there's like, what have I heard? There's like saggers and sinkers, right? And the face either slides down or it kind of hollows out. I'm probably like a sinker, I think, or I get a little hollowed out. What are your thoughts on some of those other procedures like the biostimulators like Radiesse and Sculptra? I think there's another one too. Something I can't remember.
They're both so old. They're old as I am. So I heard you talk about this with Brian. So
Yeah.
Sculptra, basically you mentioned what Sculptra does. It was brought to market for HIV atrophy in 2005. That's why it
Mm-hmm.
came to market. And of course it works. And now it's made it, full circle, and we're using it as, instead of a, quote unquote filler, it's a biologic stimulator of collagen formation in the skin.
Yeah.
So of course that's going to help you. And you can fan it out. People are
Yeah.
putting that in butts. I mean, they're doing everything with
Yeah,
Sculptra.
that's right. They're doing it in the butt. That's right. To smooth out like cellulite and things like that. Yeah. Yeah. I had it done once. It was like two little points. And I don't know. I don't mind some chic heroin look. So I don't want to go too crazy, but
Well, that's going to work. I mean, that's not really, like, to your point, that's not a filler.
no, it's not. It's a biostimulator and it's a powder that they reconstitute with saline and then it's really just so that it distributes more evenly. The worst part is having to rub your face for so many days after because it just feels like a bruise because you have had your fascia essentially like ripped, like separated, which is fascia work is so painful. Which is probably some of your patients will experience that too. If they, no matter where they've had their scars, like working that scar tissue, breaking that up is very freaking painful.
Yeah, I mean, anything that creates that level of inflammation is going to your point, it stimulates. And I like the way you explained it, with Brian. And he actually said something that most people don't say.
Hmm.
And I appreciate what he said. He's like, lasers are incredibly problematic. And I don't have a laser in my practice outside of an IPL for basically what you get from UV damage. So, in Texas and Florida and Arizona, where you are in California, you get a lot of sun exposure. And so you can get dyschromia or just pigment issues. And,
Mhm.
every 6 months or year, you can have an IPL. It's just a light-based therapy, but it's not burning your face off. It's not creating a, damage type situation. And it doesn't, for everybody listening, those things are not super effective at tightening.
They're resurfacing.
Hmm. So things that tighten are, anything that stimulates or causes enough inflammation to build collagen. And then, like we discussed
Got
offline
it.
earlier, something that cores out tissue and removes it without
Or
scarring.
microneedling would be another one that because it's a trauma to the so it sends in reinforcement skin
It's
collagen.
leveraging what your body does naturally.
Would you say steer away from the lasers then?
I don't like anything that makes a burn victim.
I've done it. I mean, I've done. I mean, and look, it's very dangerous afterwards. Like, I mean, I went out in the sun a couple of weeks after thinking, oh, I'm all healed up, but I was still essentially like not
Stuart.
healed up and I hyperpigmented a little bit. And I was like, oh shit.
Well, so you have a pretty, anything that's not going to be consistent and reproducible across all skin types, you have to be careful with. So if you're doing it and you get too much sun too quickly, you can hyperpigment. If you do it on somebody who's darker skinned, you can hypopigment them. I mean, it's just like
Yeah,
the amount
it's
of things
dangerous.
that can happen are more than you would want.
Yeah, yeah, yeah. So stick with sort of the stimulators.
I like to always tighten things,
I
and
do
that
too.
makes it easier for me to. So we got Dave coming in. We're gonna do some more tightening for him. I mean, those things make more sense to me.
I'll have to send him a message. I'll be like, where are you getting skin taken from tomorrow?
Well, yeah, we he's got appearances like you, so we can't get too crazy.
No, that's also definitely the case. So, as far as the future in your profession, like what's kind of things are you really excited about? What do you see fading out with demand or even just, the efficacy of it based on downside? And what do you love? Like what are some things what direction would you point people in? I know that you come from a very like high integrity, you're working with cancer patients and reconstruction and things like that, but the aesthetic drive of human beings is probably not going to go away. So really it's about advising us on the most wise decisions we can make to turn back the clocks. I mean, I love looking at those videos on Instagram and seeing like, this is what 40-year-olds used to look like. And this is what 40-year-olds look like now. Like we have, it is a whole different look. I mean, it's 20 now, you know?
I think it's going to be what can you use to a point about talking about skin and making a puncture or a core and getting your body to then do the work. Because your body is the most efficient performance machine you have. How can you
Amen.
leverage what it has? So I always am working on stem cell therapy personally and
Mm.
leveraging the stem cells associated with fat specifically.
Wait, wait, what?
Yeah.
Stem
So
cells associated with fat? I thought it was just for like ligaments, tendons. I mean, my sweet dog Ella, I've got her sedated on methocarbamol right now because she had both knees stem celled 2 days ago. But it was for like joints and for the ligaments. And so what do you mean?
yes, according to the FDA, we can't say that it promotes healing because then you say that's basically a drug. I've worked with adipose, which is fat derived
Mhm.
stem cells since 98. And our country's great, but it's backward in a number of ways in terms of being able to leverage what is intrinsically in your body. If I do a treatment, I can take your fat out and process it and give it back to you as your own stem cells, either
Mm-hmm.
topically or as a mid
Okay.
or IV. And I prefer your genetic material over anybody else's. Next below that would be an exosome treatment. I think you and Brian discussed that.
Yep.
Uh, so I always look at, all right, what is the best technology I have that can give you tightening? Is it coring? Is it microneedling? Is it a combination of radio frequency skin tightening and microneedling and microcoring? What combo of therapies can we give you? And then topically, what can we enhance? Um, whatever treatment we did, and I, preferentially go to stem cell therapy, but then you have exosome therapy. In our office space in Austin, we have hyperbaric. So whatever you do right afterwards, as much as you think it's boring, I'm going to put you in a chamber because you want as much of that, your body taking all of those nutrients and elements and oxygen and healing capabilities and make it as efficient as possible. So everybody who shows up wants me to do everything with no downtime, no swelling, no bruising. When can I turn my camera back on? When can I leave town? I wrote a book about SHARP, which is our method for recovery to improve the efficiency with which you can recover. And we
Is that an
discussed,
acronym?
yeah, it's a strategic holistic accelerated recovery program. Lot of words, but it means that we're accomplishing this with your body and your test results and basically supplementation rather than medication. I always have like, what's next? So you and Brian talked about HRV. You didn't really talk about biometric devices that measure it, but I'm always looking at what is the next biometric device or what is the next energy-based device. Like we didn't even talk about energy-based therapy, which is probably the most underappreciated but wide open field energy medicine. It's not really discussed. You'll get, I'll get a fair amount of heckling for this, but if you can improve energy based on mitochondrial function, and there's a lot of work being done from Joe Dispenza and
Yep.
UCSD that's going to get published by Hemal Patel, and then Energy for Life, which is a company that we work with, is developing a wearable that has a light bed that can help recharge your energy levels. So light therapy to reestablish, which, if you think about it, more like mitochondrial.
Right. I mean, I love red light. I think red light is wonderful. The number one feature I feel like it does is help with skin tone. Like I feel like it just smooths, evens, brightens. Like I love that feature, but I also understand that it has a mitochondrial up regulation to it too. Is this correct?
Also raises your testosterone levels.
Does it?
Yep. Yeah. So we have about a tall Juve red light in our clinic.
Yeah.
In front of.
Me too. I have a big 6-panel. One of the other things I've heard that's a controversial thing that's being used is GLP-1s, but I've heard that there's even an mitochondrial upregulation with those as well. Is that true?
So I would say if the drug companies knew what GLP-1s are doing now, they would have never let them be approved. Because
Say more.
if you think about what they're doing and you follow the money trail, which you just have to be very plain about this, Wall Street has moved money out of fast food and dialysis centers because you're going to see the ramifications of these drugs long term is one, a big decrease in diabetes type 2, and two, because of that, a big decrease in dialysis.
Wow.
So those are two huge money makers, right? So
well, it's like they went for the short-term win instead of the long-term one, right? You got a lifelong patient with dialysis, or you get the money quick now, and it became the number one drug sold in the world, right?
Because for your audience, what these drugs do is they modify behavior. No drug in history has done it this effectively. You take that drug, you don't even care about eating. So the amount of people in the line at Whataburger in Texas or McDonald's in Scottsdale has gone way down.
And you can get it through insurance.
Yes.
Right.
So 100%, they're just kicking themselves in board meetings all the time. They're like,
well, that's okay. They can just handle it like they handled peptides and just take them off the market and go, wait a minute.
Well, that's why
we need more regulation.
How it's not been pulled. Like, to me, the peptide thing's a joke. Like, peptides have been around forever.
Ever.
So like, okay, you found something that you want to mess with, so now you're going to pull it. That's say, it's like stem cell therapy. Like there's nothing super complicated about this. You can make it sound super complicated and make it a patient safety issue, or make us think you're making it a patient safety issue, which is not. It's more of a money issue. You want to
Yeah.
monopolize
Yeah.
and control that particular therapy
Yeah.
that you can benefit from. I get it. We're not like damn.
Right. Are you a fan of peptides? I mean, essentially GLP-1 is a peptide, right? The GLP-1's trizepatide, and the other one. They are peptides, right? So I mean, are you a fan of the peptide world? And there's so many of them.
We used them all beforehand, but ever since the FDA came down, we don't have our patients. We don't put our patients on peptides anymore because of the FDA. But
Yeah,
yes, just
exactly.
PPC 157 and
Yeah.
others routinely.
CJC 1295,
My patient,
ipamorelin,
my
all of
patient's
the
like, well, I still have some. Can I use them? I'm like, well, you can use whatever you want. I mean, it's a free country. Just you're not getting it from me because I
yeah,
can't do that. I mean, I don't. If someone's going to give us an FDA warning letter, I can't be using
100%. That's your whole practice.
things. So no, I mean, until they come down with something that guides us on what is okay in their viewpoint, no, I can't use it.
Mm. To close the loop on some of the things that were just mentioned, stem cells, something that I've done before. I went to Costa Rica with Dave, and I did plasmapheresis. I don't know if
Mhm.
you like that or not. I did stem cells intravenously as well as stem cell facial. They were not mine. They were umbilical cord, placenta, I'm assuming, checked stem cells that were, quality. I definitely got sick afterwards for a couple days, and my face totally ruptured, like broke out like crazy for 2 weeks. Look, I don't know. I mean, I look younger now than I did then, so maybe it did something. But I feel like I've heard so many mixed different perspectives on stem cells of what kind, and like, oh, maybe it needs to be your own, maybe it doesn't need to. The generally overall, like, what is the best pathway if someone wanted to do stem cells orthopedically or for anti-aging?
Yeah, I'll speak from my own experience. So I've used my own adipose-derived stem cells. Because it's your own genetic material, there's zero chance you're going to have that kind of reaction on your face. That's not going to happen. Secondly, it would be, you guys talked about exosomes. So exosomes are allogeneic, which means obviously they're from not you, but another human. And just like you're speaking about umbilical, they're allogeneic. So they're obviously the same species. You're not getting them from non-human. So those are probably first is your own, obviously, because your own genetic material, you're not going to react. Quality, people will argue as you age, the quality goes down. Whether you use those for injections in the face or a joint or an area where you're injured, that's the discretion of you and the provider you discuss it with. You can always have the IV. There are centers around the world that are doing things very, very proactive to help regenerate tissues, whether it's kidney, heart, lung, all these things that
Wow.
are beyond what we're doing in the United States. But I hope, before I'm dust, some of those things will come to the country. Otherwise, I have to go to other countries like you did.
Until then, Tijuana.
I don't go to Tijuana. Buenos Aires, but not Tijuana.
Cabo.
Yes, I like going to Cabo. I like to go to
Well,
Nobu.
Cabo's more for the superhuman injection, right? The gene therapy,
That's
which I'm
well,
stoked about. I haven't done it, but I totally will.
so that's I mean, all the things we're talking about now are what we would love to have available.
Are you a fan of that? The gene therapy?
So that's the one I know the least about.
Yeah,
So
it's the newest,
I,
right? I mean, it's
yeah. I mean, if you think about it, that's the most like next level gene therapy. Obviously,
yeah.
when I was in school, uh, you would just be like, wow, if they could do any of that, that would be incredible. And we're getting pretty close.
It's crazy with medical advances. And, I think years ago when I heard about when I feel like it was just called CRISPR, right? Like where you just like change your genes, like literally change who you are kind of thing, and how scary that was. And, then they went on to explain this is happening all day, every day in your environment. You're being affected by your genes are being affected constantly epigenetically. And that some of these therapies now you think, well, ethically it's scary, but then you go, what if your son or daughter is blind? Like, and then you could do this gene therapy and make them not blind. It's like, wow, that's actually very, very fucking cool. I mean, if we're getting into that realm, there's a lot of really great ways to, apply it. And, maybe this is the more biologically friendly way of upregulating us as human beings into a species that will live longer, be more resilient, as opposed to just putting a brain tap and wires in and uploading to Neuralink.
Looking at genomics has definitely enlightened us the most in terms of how we function and how I look at the problems that we discussed earlier about chronic inflammation. And the more you learn about that, the more you can actually affect that. Then yes, you're getting the longevity question gets answered much if you want to say in more detail. But instead of Brian spending millions of dollars, a gene therapy may supplant much of what he's had to do.
Right, exactly. He's probably has, I'm sure his pills are very effective, but he also has expensive urine. That's what I used to think about all the things that I took when I was trying to heal my gut and do all the things. I'm like, my urine, so expensive.
True. Yeah, very true.
There are some things that really work. And, I don't know what your recommendation is or your sort of vote of approval of like the direction people should go. But I mean, your body really knows what to do to heal. And so giving it that opportunity, but also like what works for you, everybody's looking for the next best thing, but what works and what doesn't work, whether it's food or workout or, biohacking, like you just know. And we try and overcomplicate it and we try and feel like we can all fit into a box, like this is the thing. But you really intuitively and physiologically get the answer very easily.
Yeah, when people seek it out from me, like certain things everybody listening can do right now is you can really pay attention to what you put in your mouth, the fluid and the food, and concentrating on sleep. We didn't touch on it, but I make a big deal about sleep in my patients because if you don't get enough quantity or quality of sleep, there's no way all the magic that happens for your body can take place at night. You need that 6.5 to 8 of uninterrupted. You really have to get through the cycles of sleep. You have to get the depth of sleep. So restorative sleep is very important. And I've had a Whoop forever, and I use Ultrahuman ring. So my patients, my female patients want to wear a ring. They don't want to wear a Whoop. So Ultrahuman is really the closest from a one-to-one comparison I have for a Whoop strap. And you can really look at your sleep in detail. But those are things that everybody can start paying attention to. And they don't require, any extra thing other than your desire to make a change.
Well, thank you very much for sharing your knowledge and for helping so many people and, ultimately just, helping us all be happier and healthier. That's the goal.
It's been fun.
Thanks, Dr. Rob. Thanks, everybody, for listening to the Pretty Intense podcast today. I hope you enjoyed it. If you like what you heard today and you want to hear more, please click on the subscribe button.